So we go with the history. Presenting 34-year-old female. She's a housewife from Ambur. She has presented bilateral upper and lower limb pain for the past 5 years. She was apparently 5 years back, around 2017, when she had developed pain all over the four limbs, and it was like a dull aching type of pain which worsened on walking after few steps, and it relieved with rest initially. But for the past 2 months, the pain has increased and it's not relieved by rest, and it's affecting her daily day-to-day activities. And she has also developed giddiness in the past 2 months, which is a head spinning sensation, but there is no history of headache, loss of consciousness, diplopia, or vomiting, or any involuntary movements. There was no history of loss of appetite and unquantifiable loss of weight, according to the bystander. But there was no history of fever, oral or genital ulcers or rashes, photosensitivity, alopecia, joint pain, or Raynaud's phenomenon. Past history wise, she had similar complaints in 2017 when she presented to the same RCMC, but she was lost to follow-up. An important finding was mentioned in that OPD chart, which I'll be later on mentioning it. And obstetric history wise, she did not have a miscarriage. She had a normal three vaginal deliveries, and the family history was nil significant. So examination wise, she was conscious oriented, a thin built lady who presented with vitals of temperature was 98 and blood pressure in all four limbs showed the upper limb was 88 by 54, left upper limb was 80 by 50. There was only discrepancy of 8 mm mercuries, and lower limb was systolic was 112 on the right and 110 on the left. Pulse rate was 78 beats per minute, which was regular, and pulses, there was discrepancy in the peripheral pulses felt. The carotids were palpable, but there was no carotidynia, that is, there was no pain or tenderness over the carotid. The brachial wise, right side was feebly present, the left side was absent. Radial bilaterally was absent. Femoral pulses and popliteal pulses were well felt, and even the posterior tibial artery pulses were also well felt. But the dorsalis pedis was feeble on the right and absent on the left. And in the OPD chart of 2017, they had mentioned that pulses were feeble, but all were palpable, but the pulses were feeble. Examination wise, she had on the general examination was nil significant, and there was no rashes, there was no ulcers, there was no non-healing ulcers, genital or oral ulcers at all, and there was no swollen or tender joints. Systemic examination was unremarkable. So this is the history and examination. A 34-year young female was come with limb claudication symptoms and with absent pulses. So I don't. Any differentials for this? Same code 164234.
The guys who are here can answer directly. The Slido can be for the ones online.
Anyone would like to answer? I said
nobody's answered it.
Yes, they have answered that guys. So the differentials initially considered is obviously medium large vessel vasculitis, probable Takayasu arthritis. Other differentials to be rolled out were giant cell arthritis, and rarely Behçet's and Cogan's can also present with iotitis. Other infectious causes like syphilis and tuberculosis, non-infectious reasons like atherosclerosis, fibromuscular dysplasia, IgG4 related disorders, and genetic defects are down another differentials. So the other investigations were normal. Counts were normal. There was no cast, no proteinuria, hematuria in the urine. CRP and ESR was normal. It was not elevated. And infectious causes were ruled out, and autoimmune causes were also ruled out, like SLE. So the CT angiogram showed a mild narrowing around in the subclavian artery, which we can see here. Okay. So the report was like there was 70% luminal narrowing of the left subclavian, and even in the bilateral lower limbs, they were reduced caliber, but the flow was present. So our diagnosis is Takayasu arthritis class 1 in our patient, because there was involvement only of the left subclavian artery, but there was no involvement of the aortic arch. So going on to Takaisu arteritis. So it's a chronic idiopathic granulomatous large vessel vasculitis. It was named after a famous ophthalmologist known Mikito Takaisu. He was a ophthalmologist who noted peculiar AV anastomosis in the fundus examination of some patients who had absent pulses. And in our patient, the fundus examination was unremarkable. It was normal, but the formal ophthalmologic evaluation is awaited. The prevalence of the disease is 3.2 to 40 cases per million, and it is usually onset is 20 to 30 years of age with a female preponderance. And racial wise, it's more common in the Southeast Asia, and also in the Asia, it is more common in the Asian countries. Pathogenesis wise, it is a pan-arteritis involving infiltration of dendritic cells, T cells, natural killer cells, and macrophages, which will lead to chronic inflammation of the vessel wall, leading to aneurysm, stenosis, or thrombosis. So, clinical feature wise, so the most predominant features are claudication symptoms. Other than that, the patient have hypertension, but our patient did not have a hypertension, but she had an unequal arm blood pressures, but not very significant. And there was no categorizing and other symptoms based on the vessel involvement. If there is vertebral artery involvement, they can have lightheadedness. If there is a central nervous system involvement, there can be stroke, and they can also have constitutional symptoms like fever and weight loss. And cardiac involvement can cause aortic regurgitation. So, and the predominant blood vessel involved here is 93% at subclavian artery, which is seen in my patient. And so this is the angiographic classification of Takaisu arteritis. It's divided into 5 types. Class 1 involves only the branches of the aortic arch. Class 2A involves the aortic arch along with its branches, ascending aorta and aortic arch. Class 2B is ascending aorta, aortic arch, its branches, and descending thoracic aorta. Class 3 is descending thoracic aorta plus abdominal aorta. 4th is only abdominal aorta plus or minus the renal arteries. And the 5th is combined 2K and 4. So the latest 22 ACR criteria for Takaisu arteritis is absolute requirement is age should be less than equal to 60 years, and there should be evidence of vasculitis on imaging. Histopathological examination is not required for a diagnosis of Takaisu arteritis. So additional clinical criteria are patient fulfilled 5 points in clinical criteria, and imaging criteria she fulfilled 1 point. One arterial criteria, subclavian was involved. So a score of 5 or more is needed for the classification of Takaisu, and our patient had a score of 6. And when the patient has Takaisu, we should know whether the patient is in active disease or in a remission. Clinical features for active disease are fever with musculoskeletal pain, elevated ESR and CRP, which is not seen in our patient. Our patient had a normal ESR and a CRP. And evidence of ischemia or inflammation like claudication, absent pulses, and angiographic features. So these are the consensus definition for active disease, major and minor relapses. Major relapses is, and there will be evidences of ischemia, and if that is not there, it's a minor relapse. So this is the algorithm for the pharmacological treatment of Takaisu arteritis. In the phase 1, we start with glucocorticoids and DMARD also, corticosteroid sparing agent, and then taper it off. But and during the follow-up, the patient has major relapse, we add on a biologicals like tocilizumab or a TNF alpha inhibitor. If there's minor relapse, we can just increase the dose of glucocorticoids. So going on to the next one. This is the paper published from our institution, published from cardiology department. This is a study, retrospective study based on percutaneous intervention procedures for Takaisu arteritis done from 1996 to 2022. This is published recently. I urge all my fellow colleagues to go through this paper. This is done from our institution. They have done percutaneous intervention to around 942 patients with 2,450 arterial lesions. In our center, we have 1,149 patients, among which 942 underwent percutaneous intervention. And based on the site, particular intervention is, it can be balloon angioplasty or a stenting. So the result was, it was showing a very good result. That it decreased the all-cause mortality and it increased the patency of the vessels. And this was quoted in the study. This Kaplan. First one is freedom from all cause mortality, sir. And the second one is a vessel patency.
What is the second one?
Vessel patency, sir. Vessels.
What is assisted patency?
Assisted is the ones who had undergone percutaneous intervention.
What is primary patency?
Primary patency is without.
The
This was a 19-year-old female who had the first image is for the time of presentation. She had collaterals, but there was narrowing. Later on, after the percutaneous intervention, that is like they have stented. After the 4 years, she has a good patency. So in our patient, we have started on steroids, and second line agent we consider was cyclophosphamide. So to my take home points are we have to start for a Takayasu arthritis a glucocorticoid plus a second line agent, all this together, and non-biologicals should always be given. And the percutaneous interventions like stenting are all reserved for life or organ threatening conditions. But this current recommendation does not favor this. But I think in future, percutaneous interventions have a major role in the treatment of Takayasu arthritis along with the pharmacological treatment. Thank you.
Sorry, what was the CRP in your patient?
That was less than 3.64.
But then why did you choose to, because what did you base your treatment on? Because you're giving high dose steroids, no? Is it the question is, was it a burnt out disease or did you think the disease was active? And if so, why?
According to the papers, it's only 50% of the patients will have a raised ESR and CRP. And for the active disease, the criteria was these criteria, like the patient has any pain and absent pulses with claudication symptoms.
Your patient had only claudication, no?
She had claudication, she had pain and absent pulses, and angiographic features were also there. So we started on steroids. She's planned for angiogram, diagnostic angiogram also.
So how are you planning to monitor the steroids? Because there is no CRP elevated. So have you looked at studies on how to monitor her, the course of therapy?
I'll check it.
Any questions, sir?
Can you show me a slide on list of differential diagnosis? See, what you have listed is all causes of missing pulses. Okay. But the exercise you should go through is that in your patient, what is the cause? From the most likely to the least likely.
Yes.
If you're putting all these things, you should say infectious are extremely unlikely. The syphilis, which artery is involved in syphilis?
Ascending aorta.
Tuberculosis, which arteries are affected?
Again, aorta can be primary central meningitis.
And atherosclerosis, 35-year-old lady,
35 less likely.
and the vessels are affected. So we should list all those things. Then other comment is that I would also agree with Dr. Ramya that steroids in her. She was first diagnosed in 2017. She never came back to follow up. Now she has come back because of ischemia due to narrowing. So she should have been referred for revascularization, and we have a department like ours, which is big series. Why she's from Ambur? Why did she not come back? Very near.
And they have severe financial constraints.
So what made her come back now?
Now the pain was intolerable, and she has come back.
So since she consult our cardiology department?
Yes, sir. We are. She's going after discharge from us. She's going to cardiologist. Thank you.